The next individual I'd like to present is Dr. Camden Kneeland. Camden is on the medical staff of Kalispell Regional Healthcare and serves as the medical director at the Montana Center for Wellness and Pain Management. He is board certified in both anesthesiology and pain medicine. His pain fellowship, training, and current practice focuses on treating hundreds of painful conditions while minimizing the use of habit-forming medications. Dr. Kneeland was born and raised in Oklahoma, where he completed his undergraduate education with a summa cum laude degree in microbiology from the University of Oklahoma. From there, he earned his medical doctorate at the University of Oklahoma College of Medicine. Dr. Kneeland was chosen as the chief resident and completed his residency in anesthesiology in Boston. Following his residency, he was chosen for one of the most prestigious pain management fellowships, the International Pain Institute at Texas Tech University. There, he worked under the tutelage of Dr. Gabor Reis. Did I pronounce that correct? Rex, thank you. Dr. Gabor Rex, one of the most accomplished and respected interventional pain management physicians in the world. Dr. Camden is here with his colleague, Dr. Chris Nadasi, and invite both the gentlemen to come up for a co-presentation. And I'm going to let Dr. Kneeland introduce Dr. Nadasi.
Thank you very much for inviting me back. I've been attending and/or presenting at this conference for almost 10 years now. And I was sitting here this morning listening to Chris and thinking, my, how far we've come. It's really encouraging to hear the shift that has occurred on the vanguard of good chronic pain management, and feel incredibly fortunate to live and work in Kalispell. And I'll tell you a couple of stories that will highlight why I feel that fortunate to be involved with that healthcare system. But I'd like to start with a story about why I'm here. You hear all the bio and all the standard stuff, and that's kind of, you know, my background, but it doesn't explain why I do what I do. So when I was in my second year of medical school, my girlfriend, who is now my wife, was hit by a drunk driver. And she was stopped at a stoplight, and he hit her going about 50, and she sustained an injury to her low back. Went through the old way, as we saw. Physical therapy, medications, ended up having a minimally invasive surgery on her disc. But as so often happens, a year and a half after the injury, she still had chronic back pain. And the system had failed her. She hadn't failed the system. So she ended up being sent to a pain specialist. Now keep in mind, I was in my second year of medical school and had been very familiar with medical specialties for quite a while. I'd never heard of a pain specialist. But as a result of the referral to this pain specialist, she received the treatment that she needed, ended up improving dramatically, and that was my introduction to chronic pain management. Now, full disclosure here, I went into chronic pain in part because it had a very good lifestyle, paid pretty well. But I also went into it because I really enjoyed the challenge of that patient population. To me, people suffering with chronic pain aren't a burden the way they are to a lot of people. My personality is such that it never has really affected me that way. And so I'm very happy doing what I'm doing. But it's interesting because as you heard from my background, I went to a pain fellowship that's widely known for being kind of the best interventional pain fellowship. And that was my focus. I wanted to do all these procedures, and, you know. What I realized within the first 2 or 3 years of my practice was that interventional pain has its role. It is important diagnostically, and for a small group of patients, it's really important therapeutically. And in my practice, it's maybe 20%. So about 20% of the patients get really good long-term relief with interventional techniques. But the other 80% of our patients, they need a lot more comprehensive treatment. Frankly, they need a lot more compassionate treatment. So when I came out of fellowship, I had been exposed to a program that had 3 parts. It was an interdisciplinary program. Those 3 parts were medical, movement in terms of physical therapy, and then mental behavioral health. And I liked that model. It was a nice fit, just felt right. At that time, I had no idea of the complexity of chronic pain and why that type of interdisciplinary model seemed to work better. So when I came to Kalispell, I told them that I wanted to build an interdisciplinary program, and they seemed to like that idea. And I thought it would be a long-term thing. I thought it would take 5 to 10 years to build something that looked kind of like what I envisioned. And to make a long story short, I got a call from the CEO about 4 months after I started there. And she said, "So the board has voted to close the pain clinic, but we want to keep you," which means, translation, we want to shut down the medical part, but we want to keep you as a needle jockey so you can make money for us. And I said, well, that's not good. But what happened is the community physicians got word of this decision and said, nope, we're not taking these people. We're not taking all these opioid patients. And so we went back to the hospital and we said, well, rather than closing it, why don't we just do it right? And so kind of overnight, we ended up with one of the most comprehensive interdisciplinary clinics in the country. So today's talk is going to be about going from there to formalizing a program called the Empower Program that really guides what we do from an interdisciplinary standpoint. You've already heard this. 90+% of our patients suffer from chronic pain. Because we have several other complementary modalities, we get patients who do not have chronic pain, a variety of physical issues, mental behavioral health issues as well. We currently have 9 different specialties within the clinic. And it is truly interdisciplinary. And I'll talk a little bit more about the difference between multidisciplinary and interdisciplinary in a second. So as you see, we're pretty busy. One of the things that's happened in the past couple of years when the CDC released their opioid guidelines in 2016, our referral volumes almost doubled. Because, obviously, these guidelines were used as an excuse not to treat people with opioids. So we went through a very difficult period of being overwhelmed, and then we added some providers, and now we're doing better. We've heard a lot about the complexity of chronic pain, and listening to Dr. Caldwell this morning, because we're very similar in age, I was thinking, yeah, pretty much everything we learned in medical school and a lot of what we learned in fellowship either is wrong or such a tiny part of the full picture that it's almost irrelevant. So it's really encouraging that we have a group of people here who understand the complexity of chronic pain and who are interested in learning more about it so that they can help people suffering with chronic pain. One of the things that's been touched on briefly by some of our presenters today is trauma, adverse childhood experiences specifically. So for those of you who aren't aware or familiar with the ACE study, I would encourage you to look it up. Its applications for chronic disease, not just pain, are profound. And hopefully we'll get into that a little bit more during the conference. The impetus that drove the creation of the Empower program was our realization as a team, universally, that if a patient didn't actively engage in their treatment, they almost never got better. And when they did get better, it usually didn't have anything to do with us. So we realized that we had to be able to educate our patients about the power that they had. And we've heard a couple of things today, one from Sean, one from Joletta, regarding self-efficacy, the term self-efficacy or self-worth. And chronic pain almost always causes a loss or a dramatic reduction in self-efficacy and self-worth. And part of it's driven by our medical model. Because, as Dr. Caldwell said earlier, we use terms like the patient failed X, right? And almost by definition, patients with chronic pain have gone through the traditional medical model and failed. And so the Empower program has as its core and as its name the goal of improving patients' understanding and ability to engage in a way that makes them realize and value their own power in their treatment. You've seen some of these data already today in other presentations. So as we all know here, it's an incredibly prevalent issue. It dwarfs, this is one of my favorite slides, it dwarfs cancer and heart disease. And unfortunately, these data still are not widely known, but it's somewhat unfortunate that chronic pain has reached a level of public awareness because of the chronic opioid issue. So I'm glad that it has increased in public awareness, as evidenced by our presentation by our senator this morning. That's a first. Certainly haven't seen that at one of these conferences before. But it's a big issue, and it's a big issue, unfortunately, in the public's mind because of opioids. The old way, so to speak, the World Health Organization analgesic ladder, which was initially intended to address acute pain. And for acute pain, it's still relevant and usually very effective. So you start with weaker and safer medications, and then you go up to opioids. Well, unfortunately, we applied this as a result of many things. Pain is the fifth vital sign. Russell Portnoy's, I'm going to call it a study, it wasn't really a study, Russell Portnoy's publication about a group of patients who did well with opioids. And, not to be forgotten, a very effective, fraudulent campaign by Purdue Pharmaceuticals to sell OxyContin, in which they told us as healthcare providers that it's safe, it's effective, and we believed them. So that's what happened. Whoops. It's what I call the biggest mistake in modern medical history. And I'm partially at fault. I still prescribe opioids. Do it a lot differently than I used to, though. So not only has the rate of overdose and death increased since those three things happened, the incidence of chronic pain has increased. We used to think the incidence of chronic pain just hadn't changed, it remained stable. But as of 2016, we have data showing us that the incidence of chronic pain is increasing. So the difference between interdisciplinary and multidisciplinary is that multidisciplinary relies on several specialties to address an issue, but it doesn't do it with a unified philosophy. You can have dramatically different ideas about how to treat X among physical therapists, physicians, etc. But an interdisciplinary approach, as it says here, are engaged in creating and applying new knowledge as they work together. And what's unsaid here is that they work together with a unified philosophy about addressing the problem. And I love the second quote. This is relatively recent. This is 2012. What many of you don't know is that interdisciplinary treatment was kind of a big thing back in the 80s and early 90s, and then the institutions who supported it realized that they were losing money and a lot of the programs shut down, which is why I feel so fortunate to be in Kalispell, because our clinic doesn't make money, period. Our clinic loses a lot of money a year. And yet we have a hospital organization that supports what we do. And that's rare. So I'm very fortunate to be there. So of all the approaches to the treatment of chronic pain, none has a stronger evidence basis for efficacy, cost effectiveness, and lack of iatrogenic complications than interdisciplinary care. So I think one of our challenges going forward is to show not that we're trying to fit into our medical model of driving up revenue, but that we can prove cost savings. That's another discussion. Most critical is the understanding that chronic pain is a disease of the person, and that a traditional, read passive, not active, passive biomedical approach cannot adequately address all the pain-related problems of this patient population. Very true. So this is who we are. Got a lot of people there. We have a little over 40 total employees, 6 medical providers, 2 MDs, myself, and an addiction specialist, 1 DO, Dr. Jennifer Jamrog, who's a neuromuscular therapist, who is trained in osteopathic manipulative medicine, 1 doctorate of doctor of nurse practitioner, and 3 physician assistants, and 5 full-time mental behavioral health providers. It's the most important part of what we do. I tell people all the time, patients all the time, that if something forced me to choose only one modality to treat chronic pain, it would be mental behavioral health. That's true. So it's a huge part of what we do. But we also have complementary alternative therapies because we know they work, and we know that people seek them out and continue to seek them out because they work. So we have chiropractic, acupuncture, massage, and as Chris put in there, a really cool therapy dog. So these are kind of who we are. This is just some of our, these are kind of the medical side of things, so to speak. Dr. Robert Kale is not on there. He's our addiction specialist. He looks kind of like Santa Claus now, actually. A lot like Santa Claus. And these are our mental behavioral health providers, one of whom is sitting next to me. Oh, there's Dr. Jamrog's under alternative services. Okay. So Dr. Jamrog is our osteopathic manipulative medicine specialist, our neuromuscular specialist. So I'm going to skip through this because this will kind of become obvious, but I'd like to introduce my colleague, Dr. Chris Nadasi, who is our clinical psychologist and whom, well, the history of how the Empower program developed is kind of hard to describe. It just kind of became an obvious thing to do. But Dr. Nadasi was a big part of that beginning. He's been with us for 8 years now, but, nice connection, he trained here at the University of Montana. So with that, I'm going to turn it over to Dr. Nadasi to talk more about the Empower program, and then obviously we'll have time bleeding into lunch for questions and things like that. Chris?
Everybody hear me okay? All right, cool. So I'm also glad to be back. I would say that the first time I was invited to speak, it came about in kind of a surprise way where Dr. Kneeland asked me to join him to talk with a few folks down at the university, and what I envisioned was a little conference room with some folks who talked about pain, maybe, and maybe one of my ex-professors, you know. And I was quite surprised to find a large room of people here. So it's possible I may have over-prepared a little bit this time. So we'll be kind of moving through some of the slides pretty quickly. So I think as a beginning point, I wanted to talk about the treatment-resistant patient. And this is some old language that we don't use anymore, but highlights why we've started to make the changes that we've made. So we spent some time already this morning talking about the wide variety of professionals that we have at our clinic and our capacity to do a lot of really interesting things with people with chronic pain that don't really fit within our traditional medical model. Despite that, we found that even though a small percentage of patients benefited from that diversity of offerings, the majority of our patients still didn't. They were treatment resistant. So what, I'm hoping this is all right, good, excellent. So what we found is that during our weekly provider meetings, we meet every Wednesday morning to talk about patients, both things that are going well and patients that aren't doing so well with our program. We found that, again, our conversations would be about oftentimes the same sort of issues, often the same patients that we'd had for many years. And we started the process before we went into this Empower model of trying to figure out ways to kind of encourage people along. And firing a patient typically did not work out very well for anybody. By firing, I mean when they've had multiple violations of pain management, medication contracts, things like that. What happens at a pain center eventually is you reach a point where you say, I'm sorry, we can't work with you anymore. And that's a sad moment for us because it means that we don't have the ability to actually influence the patient, to work with them, improve the situation. So as an alternative, we started the process of having participation in care conversations and letters, and basically those boiled down to, hey, so we need you to do something more here because without you doing something, this doesn't really go anywhere. Problem is that would occur fairly late in the process, and a lot of times really what occurred to us is we'd missed an opportunity that should have happened earlier, perhaps right at the beginning. And that awareness is ultimately what led to the development of this other way of doing things. So let's talk a little bit about what engagement isn't. So these were the sort of things that would come up during our meetings and still do sometimes. Missed or canceled appointments, non-engagement of the complementary or alternative medicine services, complete absence of self-helping behavior, or treatment-defeating behaviors. So a good example would be a person with neuropathy related to diabetes and a person who's still not managing their diabetes at all, in fact doing exactly the opposite of what they should be doing. Unmanaged stress and a variety of other emotional contributors. And then med-seeking behaviors, which I'm sure also is a term, of course, that gets thrown around in pain and primary care facilities, which is when a person comes in and it looks like their intention is just to secure medication. So we came to realize that when people came to us with a sense of agency, which is a term that is like self-efficacy. It's a belief in one's ability to affect a change. So that it's the opposite of helplessness. When they actively engaged in a variety of services, they improved. When people felt hopeless, they didn't actively engage in the change process, and they showed relatively little improvement. When we took an honest look at the outcomes of our patients and the names that kept appearing again and again in our conferences, the reality is there was a sizable percentage of our patients who were not improving, at least in a way that we believed that they could. So we started to actually redefine what we're doing with our patients. For sure, we're obviously there to treat their pain, but the primary goal that we started to focus on is this goal of engagement generally. So all of the things that we'll be talking about in the Empower program really do boil down to supporting a more active engagement in care as a necessary first step in the treatment of chronic pain patients. So this is, in some ways, a new idea, but in other ways, it's a pretty much basic idea in working with people from a therapeutic perspective. So it's a model that respects each person's unique priorities and provides support and guidance for building personal agency and a belief in the possibility of improvement. So my history of my professional life, I've worked a lot with kids and with families and designed therapeutic boarding school programs, things like that. And one of the best pieces of, one of the best observations about what it is that I do as a psychologist came from one of those kids that I worked with, and he said, really what it boils down to is you kind of steer and cheer. And actually that is basically what this program has become about as well. Okay, so in September 2014, these different ideas that were floating around started to form into a program. And again, the objectives were to address passivity or learned helplessness and to restore agency to have patients become more active in their own care. That's the cover of our handbook that we give to our patients with the acronym, of course. So, integrative medicine. As Dr. Kneeland mentioned, integrative medicine focuses on a whole person. And the focus is both on their emotional and physical functioning, their lifestyle choices, general wellness behaviors, and then focus on aspects other than just their pain. The concept here is that when we focus on these different aspects, we're actually directing resources towards improving an overall situation with the effect of also improving the person's pain. You know, I'm not going to spend a ton of time on depression, on discouragement. I mean, I'm guessing this crowd here knows that most patients who come to a chronic pain clinic have a significant amount of both. And what I would say is if you take a look through those qualities of a person who is depressed, you're also looking at what are our targets now for working with chronic pain patients. So the Empower program targets emotional factors, wellness behaviors, empowering ideas, and we'll go over a few of those today, and then optimizing the treatment relationship or the alliance. And we're very intentional about defining that in a non-traditional way. So emotional targets, depression and discouragement, helplessness and hopelessness, unmanaged stress. These are probably the top three. But as we discussed earlier in this presentation, adverse childhood experiences, a variety of other sort of, I would say, premorbid sort of psychiatric issues are also common in our patients as well. Wellness promoting behaviors. We talk with our patients about the right amount of activity, which is neither too much nor too little, and why that's important. Dietary changes, mostly focusing on reducing inflammation, oftentimes reducing weight generally. So we open up that dialogue at among our first meetings and provide support for obviously changes there. Sleep difficulties that are either contributing to their other sort of emotional, physical issues or a product of that, and then substance use. So empowering ideas. You know, as I was sitting here thinking about, gosh, I wonder what the next presentation would look like. You know, I could spend an entire session talking about this concept because these ideas, they really are empowering for patients. Most of our patients, when they come to us, are very separated from the concept that they can do anything to affect their situation. And it's no big surprise that they're separated from that. We're not a first stop sort of clinic. So by the time patients come to us, they've had a number of failure experiences in the sense that whenever their pain started, they went, hoped that it would get resolved, it didn't, and then you repeat that 50 times, and then they end up with us. So they don't come feeling powerful in their own lives. And this, for most of our patients, their day exists mostly, or consists mostly of just trying to survive it. So this concept of moving forward in some way and kind of thinking about what next and how to impact their own lives, these ideas are alien to them. I know this because I'm the second person they see, and we talk about these things, and they are truly absent in most of our patients. So the empowering ideas that come up during those initial visits, and then in a fairly systematic way throughout their contacts with our providers and our classes, a sampling of those would be the concept of a treatment partnership. That is that the patient does not fully own the process of improving their pain, nor do we. That it is a partnership that exists between us, and that if that partnership is strong, it has opportunities that are better than if either one of us alone were addressing their pain. Improvements by degree. So fairly clear with patients that the majority of our patients, at least coming in, will not experience a radical benefit from a single intervention or a single lifestyle change. It is usually some combination of things, and it's often a large collection of very small things that makes a large difference. And those differences happen by degree. So each one of those things is additive. So this, again, we're getting away from, for the therapists out there, we're getting away from black and white thinking into kind of more gray type of stuff. Indirect ways for improvement. So the concept, this concept is about rather than simply taking a medication to reduce your pain, there are other ways to indirectly improve the situation through, say, making different food choices which reduce inflammation. The reduction of inflammation improves your experience of pain. Learning to do mindful meditation, for all the reasons that were discussed earlier, is an indirect way of reducing stress and thereby reducing pain. And there are some direct, obviously, links there as well. But the concept, again, is one of restoring agency or power, but using indirect ways to confront something that directly was not confrontable. Integrative understandings of physical and emotional functioning. So this basic concept scattered throughout is that the way that we do physically, the way that we do emotionally, the stresses in our life, the sources of satisfaction or the absence of that, the relationships that we have for a lot of our patients, their spiritual engagement, all of these different things actually relate with one another. And improvement in any one area improves the overall dynamic and provides additional resources and opportunities for addressing those things that otherwise would be unchangeable. The concept of adaptation. So a lot of our patients are depressed that they cannot do the things that they used to do because they keep trying to do them the same way. And sometimes there are ways to actually either change the expectancy or the ways that they go about doing things to allow those possibilities to exist again. And again, we're back to this concept of agency or making a difference in one's life. Goal setting. It's hard to for a lot of our patients to, again, to shift into the idea that they can have goals and move towards something. So from our first visits, we start the process of goal setting. We start small, and the goals are not set by us. They're set by our patients, and they're the things that they identify as relevant in their own lives, and they define the nature of our partnership with them. And then new skills providing new possibilities for life improvement. So the concept, this concept throughout our meetings, again, is that there are things that a patient doesn't know yet that once they know, provide new opportunities for dealing with their situation differently. So helplessness is improved through having new options provided by new skills. Okay, so the Empower service components, we have a two-part intake, a medical intake and a wellness intake that occur in close proximity. The medical intake is mostly a traditional medical intake in the sense that it's a review of systems, review of pain generators, a review of any imaging, all the different things that you would expect with a thorough medical intake, as well as an introduction to a lot of the ideas that we just went over. The wellness intake then is a discussion about how are those physical aspects of life impacting a patient's overall living. So how they're doing in all those various different domains that we talked about. Ongoing support and active engagement. So this would be with each follow-up visit. There's a support of those ideas and the goals and discussion of goals and self-helping behaviors, and then behavioral health support. So the wellness intake consists, and I do all of these, so, which is really kind of interesting because I basically kind of go over the same things each time, but just because the large number of patients that we see, it really is an interesting process as a professional to see the different ways that people enter the same situation. And I'm feeling fairly confident in saying that the majority of our folks definitely do not come with the set of skills that we're going to be teaching. So I'm looking forward to doing not exactly exit interviews, but periodic interviews as well to see how that changes. Wellness intakes, though, are an assessment of emotional and interpersonal functioning, wellness-related behaviors and beliefs. We're looking for areas of resilience. We're also looking for particular challenges that basically provide indirect ways of improving the situation. There's some motivation building during the motivational assessment, essentially, and building during the intake. And then an introduction of the ideas that we talked about before. We talk about stuckness a lot, and that gets snickers because obviously that's not a real word. So. Okay, supported active engagement. So again, this is a patient-centered partnership. So the way this is described to a patient during their second visit with us is that their benefit from care is going to be based on the quality of the relationship with their provider, which is a partnership that will be focused around their goals. I give assurances that, of course, we'll be bringing expertise in pain management to that and traditional sort of methods. And we want to know what's important to them. When we know what's important to them, we'll know that we're working on the same things, and as we do that, we're more likely to have success. Patients typically are a combination of relieved and confused by this idea because a lot of our patients have been trained to be good patients, which means compliant patients. Sometimes actually pretending to take meds that they're not actually taking, because that's what a compliant patient does, or carrying on with some course of suggestions like a particular physical therapy that was like hurting them, but they didn't want to say anything. So we actually are encouraging our patients to be more vocal in what they want, starting with their goals. And let's see, encourage self-helping lifestyle behaviors. So a lot of the goals really kind of, when I say that patients set their goals, we do provide a little guidance around the goal setting, obviously. But the goals typically involve things like changes in their eating, changes in their activity level. For a lot of our patients, it's increased social engagement, things like that. So there's an ongoing kind of checking in about how those things are going, and truly a steer and cheer sort of approach in the follow-up visits. So our follow-up visits just aren't about med checks and about supplying referrals just for acupuncture or some other alternative approach. And then, of course, this is continued across all of our patient-provider contexts. Okay, so skill development. We have two different ways that we approach skill development. Most of our patients involve themselves in individual counseling at some point in their care. So skill development is a component of that individual counseling. Although, in truth, individual counseling usually focuses at least as much on managing present stressors or starting to kind of unpack stuff that has been stressful and difficult for the patient for many years. We also have classes. We have 9 different classes presently. Classes are not group psychotherapy. They're actually didactic classes, interactive didactic classes. As you can see, we cover a variety of different topics. Probably most of you recognize pretty readily are related to pain management. Anyone who doesn't know what Qigong is, it's a meditative, essentially a martial art, meditative martial art that's similar to yoga. I would get in trouble for describing it that way, but it has a, so the way that So about yoga. So we actually find that most of our patients are inactive, and for them to become more active, we need to start small with them. For years, we've been offering yoga classes. And our community, which I think is different than Missoula, people don't always respond well to yoga. And I can tell you that 1 out of 5 intakes, if I mention yoga, I get some version of, I'm not going to do that religion. And so we do gentle movement, which is similar to yoga, but we also then offer some other movement opportunities as well. So. And I only say that because a lot of you guys are probably practicing smaller communities too. And I would say I answered just as many questions about acupuncture as well. There is, not surprisingly, not a lot of good information about these alternatives. So when people don't understand the alternative, of course they're not going to actually pursue it because they already have some understandings about it that would prevent that from occurring. Okay, so how am I doing on time? Or is there like a little... Oh, 10, yay, cool. I had some fear I wasn't gonna make it through all this, so I'm going to, good. Okay, so we really started this program in earnest last summer. And I would say that there's been a number of different things that we've learned along the way that have allowed us to make it something that is more of our culture now and less of a new addition. And we got to a point where we were feeling comfortable enough with it being our default culture that we were able to start collecting data. So we're working with a doctoral level student, Lori Mariani, to actually, oh, that's not good. Yeah, okay, well anyway, that was the last slide. So, we're working with Lori to take a look at a series of different things that we believe, hopefully, are going to be true of this way of working with patients, that their perceptions about their pain will change, that their feelings of depression, disengagement from life and from their openness to services, their rate of showing up for appointments, making appointments, their engagement in additional mental health services, that all of these different things will show a shift as a result of a different process of working with them right from day one. And we're assessing this through information that's just readily apparent in their records, in terms of, like their appointments showing up, things like that. We're also using some assessment devices provided through WellBrain, which we've already talked about today. They're tablet administered sort of devices taking a look at depression, anxiety, patient perceived disability, and some other factors as well. So we're hoping that, and then we assess them every 3 months. So they're assessed when they come in, and so it's longitudinal. So we're hoping actually by next year at this time we'll have some other interesting things to talk about that are data-driven sort of observations about how this approach is working. It's a pretty good chance we'll probably revise it a little bit before then as well. What were the other things on that last slide? Questions. Oh, questions, okay. Oh, no, there was a comment about culture change too. Okay, so one of the things that is interesting to change is our own thinking because, as I said, we have this weekly provider meeting, and the provider meeting in part is to discuss any variety of different things, but ultimately our attention usually goes to how can we get this person kind of up and running because we're running into some problem with them, right? So catching ourselves and changing our own culture, getting away from words like compliance, and resistance and stuff like that. It's a really interesting process of shifting our thinking about that. I would say that if I was a patient walking into this environment, I'd be kind of excited about it, it'd be cool. But I think a typical patient is not super excited about or doesn't understand it right from the very beginning about, now what am I supposed to do now exactly? Because, tell me what to do, which is actually really what we don't want to do, to tell them what to do. So this process of changing cultures within our patient happens on a per patient basis every single time we get a patient. The process of changing culture within our clinic has been a cool thing to watch over time. I think I would agree with Dr. Kneeland that we started out with kind of like an optimal situation in terms of a variety of different disciplines from people with different backgrounds and really easy personalities with a dedication to what they're doing for a variety of different reasons. So we started all out, I think, in an optimal situation. And it's still a challenge at times to overcome some of those automatic assumptions we have about patients and about what it means to be a provider. So I'm just offering this observation because if you like these ideas and you want to do this sort of stuff in your practice, expect to confront some of these things within yourself and expect that even when you start to make sense of it, what's going to happen is you're still going to be actually finding yourself explaining it in better and better ways to each patient every time when you first have a patient into your clinic. Okay, questions? And she gave me the little 5 sign.
One comment here. Is this working? Oh, good. All right. To build a little bit on Chris's comment about a culture change, as healthcare providers and certainly as physicians, there is a tendency to, not just based on personality, but based on the way we're trained, there's a tendency to expect to be and want to be in the position of controlling the patient's treatment, right? So what Chris is talking about is that as providers, respecting this balance of power, we have to be willing to let go of our own expectations of being able to control the patient's outcome. And that can be hard. It can be a lot harder for some people than others. I'm sitting here thinking about trying to sell this model to a neurosurgeon. But something to think about, because there really is a balance of power or a balance of control, so to speak, that has to be respected, and it will select for certain patients and certain providers. We've been fortunate so far that we haven't had any significant issues with that, but there are some people who are better at it than others.
I guess the other comment that I'd like to make about this too is that when we forget, when we become too active and direct something, we're actually, through that process, even if it's for the best of reasons, we are encouraging passivity. And remember, if we go back to the idea that restoring agency is the primary goal here, anything that encourages passivity works against that goal. So, and that's a hard thing to kind of keep balanced in our heads sometimes, admittedly. Okay, questions?
Here, I'm bringing the mic over. Guys, we're probably going to have time for 2 questions.
I have 2 questions in one. Is that okay? I have 2 questions, actually, really quick. With the recent media attention on the opioid epidemic and chronic pain, do you see any improvements in reimbursement? And number 2, have you ever used chronic pain support groups? And if you have or have not, why or why not?
So the answer to question number 1 is I've seen a lot of new and powerfully backed initiatives to improve access and reimbursement to opioid-related adverse events, primarily addiction. I've not yet seen a lot of meat to the few initiatives I've seen regarding specifically chronic pain management. It's the focus on the opioid overdoses and the opioid deaths, which is certainly good. We need a lot better services to address that. But I guess the short answer is not yet, but I think it's coming. Chronic pain support groups. I was actually asked about chronic pain support groups by a patient this week, and we have not at our practice had a chronic pain support group. There has been one in the Flathead Valley for quite some time that kind of waxes and wanes in terms of attendance, but certainly recognize their value, but we don't have one.
So yeah, so there was a brief time where one of our counselors tried to do that, and it didn't go well. This was a while ago, but the culture was different. So I think now that we have a class-based culture, we have been talking about doing some not just broad support groups for chronic pain, but more group-based psychotherapy for specific clinical issues that are common in our patient population as well. We're also talking about doing a peer mentorship program. Some of our patients come in with that really just wonderful sense of agency, and they kind of get this, and they've been kind of taking this stuff on, and they're able to talk about that. And sometimes I think that the messages that would come from a peer with pain would be different than what would come from a professional, and so we see a benefit. So we've been politely asking those folks if they would be willing to do that when we're ready, and we actually have about 20 folks who are willing to actually be participants in that program. So maybe within the next 3 months or so.
Patients self-refer or need a referral?
For
your clinic?
You want to handle that?
Both. The vast majority of our patients, probably 80%, come via referral. We do not require referrals. The only time referrals may be formally necessary would be in the case of insurance requiring a referral to cover their services, but our policies do not require a referral.
What is your payment model, and do you find that payer source is a barrier for patients to participate in the entire program with the alternative therapies?
Yeah, so our particular patient demographic is not well suited to complementary alternative out-of-pocket expenses. We have 60% Medicare, Medicaid, about 10% workman's comp, 20% private pay, or self-insured, I should say, and then about 10% uninsured. So it is certainly a barrier to specifically our patient population. Fortunately, we have, although it is changing with the financial realities of medicine these days, we have had traditionally a very liberal financial assistance program that has allowed very good access to things that are not covered, like acupuncture and massage. So that will continue, although, as I said, with the financial challenges of modern medicine, the financial assistance programs are becoming less liberal.
And I would say regarding other aspects, like our classes, because we ran into some questions about how those could be billed, we just made the decision to offer those for $5 each, and then to kind of liberally hand out vouchers for those classes at the outset. So back to Dr. Kneeland's original comment, I mean, we have a lot of support, and we realize that that's not typical, but at the same time, it's allowing us to actually offer some of these ideas and supports to our patients in a way that gives us a chance to do something different.
Thanks, everyone, and hopefully you can catch Chris and Camden during lunch. Thanks.
Thanks.
We've got a couple of final announcements before we go to lunch.